Gallstone disease. Cholelithiasis. Choledocholithiasis. Definition. Gallstones, or choleliths, are solid masses formed from bile precipitates. These stones may occur in the gallbladder or the biliary tract. Gallstone disease refers to the condition where gallstones are either in the gallbladder or common bile duct. The presence of stones in the gallbladder is referred to as cholelithiasis, from the Greek chol, bile, plus lith, stone, plus iasis, process. Presence of gallstones in the common bile duct is called choledocholithiasis, from the Greek chol, bile, plus docho, duct, plus lith, stone, plus iasis, process. It is frequently associated with obstruction of the bile ducts, which in turn can lead to cholangitis, from the Greek, chol, bile, plus an, vessel, plus itis, inflammation, a serious infection of the bile ducts. Gallstones within the ampulla of Vater can obstruct the exocrine system of the pancreas, which in turn can result in pancreatitis. Statistics and incidences. Choledocholithiasis is becoming a common phenomenon worldwide. Cholelithiasis is a common health problem, affecting 50% of white women and 30% of white men. Out of every 10 patients with cholelithiasis, 1 develops choledocholithiasis. Gallstones are uncommon in children and young adults but become more prevalent with increasing age, affecting 30% to 40% of people by the age of 80 years. Types. Composition. From left to right: cholesterol stone, mixed stone, pigment stone. Gallstones can vary in size and shape from as small as a grain of sand to as large as a golf ball. The gallbladder may contain a single large stone or many smaller ones. The composition of gallstones is affected by age, diet and ethnicity. On the basis of their composition, gallstones can be divided into the following types: cholesterol stones, pigment stones, and mixed stones. Cholesterol stones. Cholesterol stones vary from light yellow to dark green or brown or chalk white and are oval, usually solitary, between 2 and 3 centimeters long, each often having a tiny, dark, central spot. To be classified as such, they must be at least 80% cholesterol by weight, or 70%, according to the Japanese classification system. Between 35% and 90% of stones are cholesterol stones. Pigment stones. Bilirubin, pigment, black pigment, stones are small, dark, often appearing black, and usually numerous. They are composed primarily of bilirubin, insoluble bilirubin pigment polymer, and calcium phosphate, salts that are found in bile. They contain less than 20% of cholesterol, or 30%, according to the Japanese classification system. Between 2% and 30% of stones are bilirubin stones. Mixed stones. Mixed, brown pigment stones, typically contain 20–80% cholesterol, or 30–70%, according to the Japanese classification system. Other common constituents are calcium carbonate, palmitate phosphate, bilirubin and other bile pigments, calcium bilirubinate, calcium palmitate and calcium stearate. Because of their calcium content, they are often radiographically visible. They typically arise secondary to infection of the biliary tract, which results in the release of beta-glucuronidase by injured hepatocytes and bacteria, which hydrolyses bilirubin glucuronides and increases the amount of unconjugated bilirubin in bile. Between 4% and 20% of stones are mixed. Pseudoliths, sometimes referred to as sludge, are thick secretions that may be present within the gallbladder, either alone or in conjunction with fully formed gallstones. Risk factors. Age over 40 years. Crash dieting, or losing weight rapidly, the bile then contains more cholesterol. Diabetes. Ethnicity, risk is higher in American Indians and Mexican Americans. Family history. Female gender. Liver disease. Overweight or obesity. Pregnancy decreases the gallbladder's ability to empty bile. Use of certain medications, cholesterol-lowering drugs increase cholesterol in the bile. Causes. It's not clear what causes gallstones to form. Doctors think gallstones may result when bile containing too much cholesterol. Normally, the bile contains enough chemicals to dissolve the cholesterol excreted by liver. But if liver excretes more cholesterol than bile can dissolve, the excess cholesterol may form into crystals and eventually into stones. Bile containing too much bilirubin. Bilirubin is a chemical that's produced when body breaks down red blood cells. Certain conditions cause the liver to make too much bilirubin, including liver cirrhosis, biliary tract infections and certain blood disorders. The excess bilirubin contributes to gallstone formation. Gallbladder doesn't empty correctly. If gallbladder doesn't empty completely or often enough, bile may become very concentrated, contributing to the formation of gallstones. Pathophysiology. Sign and symptoms. Abdominal pain, typically localized to the right upper quadrant of the abdomen. Abdominal swelling, distension or bloating. Abdominal tenderness. Clay-colored stools. Nausea with or without vomiting. Pain that radiates from the abdomen to the right shoulder or back. Sweating. In a small number of people, gallstones can cause more serious problems if they obstruct the flow of bile for longer periods or move into other organs, such as the pancreas or small bowel. If this happens, client may develop a high temperature of 38°C, 100.4 F, or above. More persistent pain. A rapid heartbeat. Yellowing of the skin and whites of the eyes, jaundice. Itchy skin. Diarrhea. Chills or shivering attacks. Confusion. A loss of appetite. Assessment and diagnostic findings. History taking. The nurse notes a history of smoking, previous respiratory problems, shallow respirations, a persistent or ineffective cough, and the presence of adventitious breath sounds. Physical examination. Complete head-to-toe examination to be carried out. Patient may have tenderness and pain on palpation of the upper abdomen. Abdominal computed tomography, CT, scan. Abdominal CT scan may detect stones in the gallbladder. Percutaneous transhepatic cholangiography, done under fluoroscopic control, distinguishes between gallbladder and bile duct disease and cancer of the pancreatic head in patients with jaundice. Endoscopic retrograde cholangiopancreatography, ERCP. ERCP visualized the biliary tree after insertion of the endoscope, down the esophagus to the duodenum, cannulation of the common bile duct and the pancreatic ducts, injection of the contrast medium. Hepatic biliary immunodiacetic acid, HIDA, scan. HIDA scan detects obstruction of the cystic duct. Magnetic resonance cholangiopancreatography. This scan can detect gallstones, choledocholithiasis, masses, biliary stricture, and dilation. Abdominal X-ray. If gallbladder disease is suspected, an abdominal X-ray may be obtained to exclude other causes of symptoms. Ultrasonography. Ultrasonography has replaced cholecystography as the diagnostic procedure of choice because it is rapid and accurate and can be used in patients with liver dysfunction and jaundice. Cholecystography. Oral cholangiography may be performed to detect gallstones and to assess the ability of the gallbladder to fill, concentrate its contents, contract and empty. Management. Medical management. Non-surgical treatments are used only in special situations, such as when a person with cholesterol stones has a serious medical condition that prevents surgery. Gallstones often recur within 5 years after non-surgical treatment. Two types of non-surgical treatments can be used to dissolve cholesterol gallstones. Oral dissolution therapy. Ursodeol, Actigel, and Choledocholithiasis, Genex, are medications that contain bile acids that can dissolve gallstones. These medications are most effective in dissolving small cholesterol stones. Months or years of treatment may be needed to dissolve all stones. Shockwave lithotripsy. A machine called a lithotripter is used to crush the gallstone. The lithotripter generates shock waves that pass through the person's body to break the gallstone into smaller pieces. This procedure is used only rarely and may be used along with ursodeol. Surgical management. Surgery to remove the gallbladder, called cholecystectomy, is one of the most common operations performed on adults. Once the gallbladder is removed, bile flows out of the liver through the hepatic and common bile ducts and directly into the duodenum, instead of being stored in the gallbladder. Surgeons perform two types of cholecystectomy. Laparoscopic cholecystectomy. In a laparoscopic cholecystectomy, the surgeon makes several tiny incisions in the abdomen and inserts a laparoscope, a thin tube with a tiny video camera attached. The camera sends a magnified image from inside the body to a video monitor, giving the surgeon a close-up view of organs and tissues. While watching the monitor, the surgeon uses instruments to carefully separate the gallbladder from the liver, bile ducts, and other structures. Then the surgeon removes the gallbladder through one of the small incisions. Patients usually receive general anesthesia. Open cholecystectomy. An open cholecystectomy is performed when the gallbladder is severely inflamed, infected, or scarred from other operations. In most of these cases, open cholecystectomy is planned from the start. However, a surgeon may perform an open cholecystectomy when problems occur during a laparoscopic cholecystectomy. To perform an open cholecystectomy, the surgeon creates an incision about 4 to 6 inches long in the abdomen to remove the gallbladder. Patients usually receive general anesthesia. Recovery from open cholecystectomy may require some people to stay in the hospital for up to a week. Normal physical activity can usually be resumed after about a month. Nursing management. The patient who is to undergo surgical treatment of gallstones is often admitted to the hospital or same-day surgery unit on the morning of surgery. Nursing assessment. Assessment should focus on the respiratory status. History. The nurse notes a history of smoking, previous respiratory problems, shallow respirations, a persistent or ineffective cough, and the presence of adventitious breath sounds. Nutrition. Nutritional status is evaluated through a dietary history and a general examination performed at the time of pre-admission testing. Laboratory results. The nurse reviews previously obtained laboratory results to obtain information about the patient's status. Nursing diagnosis. Based on all the assessment data, the major nursing diagnosis for the patient who has choledocholithiasis and has undergone surgery may include the following. Acute pain related to surgical incision. Impaired gas exchange related to high abdominal surgical incision. Impaired skin integrity related to altered biliary drainage after surgical intervention. Imbalanced nutrition, less than body requirements, related to inadequate bile secretion. Nursing care planning and goals. The goals for the patient include relief of pain, adequate ventilation, intact skin and improved biliary drainage, optimal nutritional intake, absence of complications. Nursing interventions. Patient care for gallbladder and bile duct diseases focuses on supportive care and close postoperative observation. Lung exercises. Before surgery, teach the patient to cough, deep breathe, expectorate, and perform leg exercises that are necessary after surgery. Patient education. Explain the procedures that will be performed before, during, and after surgery to help ease the patient's anxiety and to help ensure his cooperation. Post-surgery monitoring. After surgery, monitor the patient's vital signs for signs of bleeding, infection, or atelectasis. Incision site care. Evaluate the incision site for bleeding. Serosanguinous drainage is common for the first 24 to 48 hours if the patient has a wound drain. T-tube care. After a choledochostomy, a T-tube drain is placed in the duct and attached to a drainage bag, so make sure that the drainage tube has no kinks and check that the connection tube from the T-tube is well secured to the patient to prevent dislodgement. T-tube drainage monitoring. Measure and record T-tube drainage daily, which has a normal amount of 200 to 300 milliliters. Iando monitoring. Monitor the patient's intake and output. Pain management. Evaluate the location, duration, and character of the pain, and administer adequate pain medications, especially before activities that increase pain. Evaluation. The expected patient outcomes include relief of pain, adequate ventilation, intact skin and improved biliary drainage, optimal nutritional intake, absence of complications. Complications: acute cholecystitis, sudden inflammation of the gallbladder; cholangitis, an infection or inflammation of the common bile duct; Choledocholithiasis, gallstone in the common bile duct; pancreatitis, infection or inflammation of the pancreas. Prevention: eating a healthy diet, getting regular physical activity, losing weight slowly, maintaining a healthy weight.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.